Hello everyone, myself Dr. Priyanka and I'm one of your mentors for Study EPCOG. So today we are back with the YouTube series, the RRR series for the EPCOG part 1 where we discuss the important modules and the important EMQs and the single based answers also which are important for the exam point of view. So always remember that never put a limit on what you can do. So first we will discuss few EMQs which are important for the exam, and then followed by that we will discuss the SBS. Before that, before discussing that, I would just like to tell that we are regularly posting the YouTube videos. So do like, share, and subscribe Study Medic channel, and also press the bell button icon to get updates on the recently added videos. So first we will discuss the EMQs. So this is a 45-year-old woman who had a complaints of urgency, frequency, and micturition. So she was diagnosed with overactive bladder and was started on lifestyle measures. So which is the first line management for overactive bladder, we know. So she has 6 weeks of bladder training and with mild improvement. So what's your next management? So she is diagnosed with overactive bladder, and the first line management is lifestyle. So which is effective, but there is mild improvement. So what's the next step in the management of this woman? So out of this, so in overactive bladder, if we know if the lifestyle measures fail, then we move to the medical management with the lifestyle measures. And the drugs that are used in case of overactive bladder are the anticholinergic, that is antimuscarinic drugs. So the answer here is anticholinergic drugs, which can be first is the bladder training, which we offer for 6 weeks, and if it has little benefit or no benefit, then we can change. We can start the patient on the anticholinergic drugs, and who do not have satisfactory benefit from the bladder training program. So this is according to the NICE urinary incontinence guideline. So, what can be the symptoms of overactive bladder? So, the most frequent symptoms seen are the frequency, urgency, there can be nocturia, and there can be hesitancy. Sometimes there can be incomplete emptying of urine, and sometimes straining. There can be weak urine stream. So, there can be varied symptoms that can be seen in case of overactive bladder. So how do we manage a case of overactive bladder? We do take a proper history, find out any risk factors, and by that we do the examination. And then in the management, first is always the lifestyle measures. In any urogynecology case, the first line management is the lifestyle measures, where we, if they are obese, we tell them to reduce, manage the BMI by referring them to the dietitian, do diet modification, fluid management. We tell them to even chart bladder diary, and also give them lifestyle measures, 6 weeks of bladder training. And if these measures fail, then we start them on the medical management, that is overactive bladder drugs. And the most commonly used are the oxybutynin, tolterodine, dariphenacin. Depending upon the age, depending upon the risk factors the patient has, the drug of choice will be different. After this medical management fails, the next step is to do the urodynamics test, and also this is the time when we involve the urogynecologist. The third line management are the invasive measures, which consist of Botox, that is botulinum toxin A, and percutaneous tibial nerve stimulation and sacral nerve stimulation. The last fourth line measures are surgery if the previous management fails, and it is by doing the augmentation cystoplasty or by urinary diversion. Then these are the options that are given. So it's a 66-year-old woman who has presented. So she's 66 years old. She has presented with painless hematuria since 3 months, and there is associated weight loss and increased frequency of urination. She is a chronic smoker and smokes 10 cigarettes per day. And a cystoscopy was done. So this is the picture of the cystoscopy. So what can be the probable cause for her hematuria? So if you take into account the different risk factors she has, so she is 66 years old, and there is painless, okay, so there is painless hematuria, and she has risk factors that there is a, she's a chronic smoker and smokes 10 cigarettes per day, and there is also history of weight loss. So these all point towards a sinister pathology like bladder carcinoma, where there is complaints of painless hematuria. Okay, so the answer here would be E, that is bladder carcinoma. So she has all the signs of a bladder cancer. The causes, the risk factors can be smoking, as the patient has. There can be repeated recurrent UTIs, exposure to some chemicals like aniline dyes, or chronic catheterization, or exposure to radiation. Chemoradiation can also increase the risk. Like there are some drugs like cyclophosphamide which can also increase the risk of bladder carcinoma. What can be the symptoms? There can be painless hematuria, there can be increased frequency, sometimes there can be painful urination, and there can be suprapubic pain, there can be fatigue, weight loss, as this patient, like cachexia symptoms like weight loss, increased loss of appetite, and there can be bone pain. So these are the features of bladder cancer. So these are the options, and the case is there is a 65-year-old woman who presents with a complete vaginal wall prolapse. So she had hysterectomy 10 years ago for fibroid uterus, and now she is after the hysterectomy with wall prolapse. And she has been informed that following an operation for correcting her prolapse, occult urinary incontinence may manifest, that is de novo incontinence in the form of stress urinary incontinence. And she asks whether is there any procedure which can help her reduce the chance of this urinary incontinence that develops after surgery. So what is the preventive measure for this incontinence, uh, uh, for this woman who already has a hysterectomy done? So here we can do a scalpo suspension, which can be done to prevent further occurrence of a de novo SUI. That is, the answer here is colpo suspension with sacrocolpopexy, because she is already hysterectomized. It's a case of a wall prolapse. So colpo suspension is where if you can see, that is the iliopectineal ligament or Cooper's ligament. So there is, the sutures are placed in the, like in a hammock fashion, you can see, which support the sphincter and the urethra, and can reduce the risk of developing post-operative SUI. So that's the case of a Bush colpo suspension. Now there is a 76-year-old woman who, postmenopausal woman, who complains of leaking of urine with cough, and there is and running. So you can see that she has symptoms of stress urinary incontinence, clinical stress urinary incontinence. Her examination is unremarkable, and her blood tests are normal. Her urine analysis, there is no UTI, there is no infection. She has tried basic lifestyle measures which has failed, and she then underwent urodynamic study, which shows the following. So here in a urodynamic study, it is done. The three pressures are measured: the bladder pressure, that is the P vesicle, which you can see, it's the above the pink one, and the middle one, the blue one, is the abdominal pressure, and the lower red one is the detrusor pressure. So normally, vesical pressure is measured by inserting a catheter in the bladder. Abdominal pressure, either the catheter is inserted into the vagina or rectum. And detrusor pressure is when we subtract the abdominal pressure from the vesical pressure, we get detrusor pressure. So normally, whenever there is cough, if we tell the patient to cough on urodynamic chart, there will be increase in the abdominal pressure because the patient is coughing, and there will be increase in the bladder pressure also. But we shouldn't see any leak normally when there because due to intra-abdominal pressure, there will be only increase. If we see any leak associated with increase in abdominal and intravesical pressure, then it's a case of a stress urinary incontinence. So it's a proven urodynamic diagnosis, and hence the answer here would be just not only stress incontinence, but a D, that is urodynamic stress incontinence. So urodynamic stress incontinence, when it's a urodynamic diagnosis, when there is increase in abdominal pressure, increase in the vesical pressure, and no change in detrusor pressure, and there is associated leak. If you see there is only increase in abdominal pressure and increase in vesical pressure without any leak, that's a normal finding. If just because the patient has cough, there is increase in abdominal pressure, and there will be normally increase in vesical pressure. Detrusor overactivity is when there is involuntary leakage of urine. So in the storage phase, okay. So detrusor pressure shouldn't increase during the storage phase of the cycle. So if there is increase in the detrusor phase, detrusor pressure, and if there is associated leak, so we call it as a detrusor urge incontinence, or we can call as wet detrusor overactivity. If there is increase in vesicle pressure, increase in detrusor pressure, but if there is no a leak, then we call it as wet dry detrusor overactivity. Mixed incontinence is when we see both the features of detrusor overactivity and urodynamic stress incontinence. Now there is a patient who complains of urgency and frequency, and on urodynamic testing, the first sensation to void is 100 ml. So, and the bladder capacity is 350 ml. On provocation, detrusor contractions strongly noted during the filling phase, but with no leakage. Okay. So here you can see that the capacity, the first sensation, and also the total bladder capacity is slightly reduced in this patient. And as I said, that during the storage phase, during the filling phase, we should not see any detrusor contractions as we are seeing here. So the lower line is the detrusor pressure, which is increased during the filling phase, and the arrows that you can see, blue arrows, and but there is no leak. So it's a case of a detrusor overactivity, or we can call it as a dry detrusor activity, because it is not associated with leak, and only there is increase in the detrusor pressure. Without any leak is dry detrusor activity. If there is increase in the detrusor pressure, but if there is associated leak, we call it as during filling phase. Okay, it is called as wet detrusor activity or urge incontinence. So you can see here during the in between there is rise in the blue and the red pressure. That is when the patient must have coughed that time. So that's why the abdomen pressure is increased, and also the that time the vesical pressure is increased, but there is no leak associated. So this is normal finding. So now there is a 45 years old lady who previously had step surgery for incontinence. So she had previously history of surgery for incontinence 10 years ago, and now she is having stress urinary incontinence. Her general and local examination is unremarkable, and she has strong pelvic muscle when you assess. So what is your initial management plan for her? So she is already means that her incontinence surgery has failed, because she had previous history of surgery for incontinence, and now she has symptoms of SUI. So it's a previous failed surgery for incontinence, in which that is an indication to do a urodynamic study. So the answer here is G. So there are few indications to do a urodynamic study according to the NICE guideline. So if there is de novo stress incontinence, that's not an indication. But if there is a history of failed surgery for an incontinence and the patient has developed new symptoms of SUI, then that's a surgery indication for urodynamic study. Or if there is an anterior or apical prolapse, or if there is symptoms suggestive of voiding dysfunction, or if there is complaints of missed incontinence where the predominant type is unclear. In that case, these are the indications to do a urodynamic study. So in this case, there is a previous history of failed surgery for the stress urinary incontinence. Now, there is a 66-year-old lady who presents with a history of difficulty in micturition. She voids 3 times a day with large volumes. She has no stress symptoms or urgency. So, we had done her urodynamic study. It has shown a flow rate of 3 ml per minute, which is slightly reduced. Normally, it should be 15 ml per second. And the bladder capacity is quite large. It is 800. So it's the bladder capacity should be normally in adults it should be 450 to 600 ml, and voiding time is also increased 320 seconds. Her first desire to void is also at 400 ml. So it is normally at around 150 to 200 ml, and second desire to void is at 600 ml, and urgency at 800 ml. So what is the likely cause? So you can see the stream is slow, and also the bladder capacity is increased, which is likely suggestive of the outflow tract obstruction, where the answer is E. So she has a history of larger blood volumes, and as I said, the normal urine flow rate is greater than 15 ml per second. In her case, it is 3 ml. So the flow rate is reduced, the bladder capacity is increased, Means there is a case of a poor outflow obstruction, which can be the cause. It can be or poor detrusor function. So these are the normal urodynamic parameters. In this case, we see that the bladder capacity is increased. It is 800 ml. First desire to void also in the case was 400 ml, which is normally should be 150 to 200. And the flow rate is also slow. It's 3 ml per second. So it's a case of outlet obstruction. Now, there is a 41-year-old woman who presents with a long history of probable recurrent UTI and has been treated with presumptive antibiotics when she lived abroad. She has pain in the bladder area and also urinary urgency, but no leaks, and occasional hematuria that resolves spontaneously. So serial urine cultures have always been negative, and including for fungus and or typical bacteria. So she has a recurrent history or history of recurrent UTI, and where there is antibiotics which has she has taken which has failed. So what can be the management that you can do in this case? So it's a case of a bladder pain syndrome, or also called as interstitial cystitis, where we are going to do further test in the form of cystoscopy and bladder biopsy, where to look for the specific lesions that are seen in case of interstitial cystitis, called as recurrent Hunner lesions. So, in bladder pain syndrome, again, the main first line management is the lifestyle measures, where the patient usually come with complaints of chronic pelvic pain more than 6 months, where all the investigations have been normal. There is no history. There is no the urine test is normal. So here the management is empirical. We give analgesics for the pain relief and tell them to avoid stress, and some dietary modification to avoid citrus or foods that can be bladder irritants. We can tell them to avoid, and also some form of exercise and physiotherapy. Then the next line of management is the empirical medical management by giving the oral amitriptyline and cimetidine, that is the H2 receptor blocker. Third line managements are giving the local management, that is giving intravesical DMSO or heparin sulfate or Botox A injection. And the fourth line are the neuromodulation or cyclosporin A. And fifth line, where all the measures are failed, we do cystoscopy and hydrorestention to look for the specific lesions. So, what are the differential diagnoses? So, bladder pain syndrome, it's a diagnosis of exclusion, where we rule out other gynecological and non-gynecological causes which can cause chronic pelvic pain, like other urinary problems like bladder cancer, or some gynecological causes like cervical or uterine ovarian cancer. And we do specific investigations according to the suspicion. We do the cause investigations, we rule out, and then we label the patient as having bladder pain syndrome. So we tell them to chart a bladder diary for at least 3 days, and a food diary to look if there is any specific food which can cause these symptoms, and urine microscopy to rule out UTI. So all these are to rule out the other causes. Ultrasound to look for any case of an endometriosis or adenomyosis which can cause chronic pain, and to look for history of any STIs, to look for STI testing. And but cystoscopy we do to see for any lesions specific for bladder pain syndrome. So of these are the list of drugs. So which of the following list, which is the selective serotonin and noradrenergic reuptake inhibitor? That is the which of this is the SNRIs. So here the most common drug that we use for the management of stress urinary incontinence is the duloxetine, which is the selective serotonin and noradrenergic reuptake inhibitor. Okay, which is used for the medical management of stress urinary incontinence. Now there is a 50-year-old lady with urgency, frequency, and intractable nocturia. Okay, so there is a 50-year-old. In 50-year-old, so she has a clinical picture of an overactive bladder. So what is the considering that the lifestyle measure has failed? So what is the medical management that we can give in her case? So there can be you can think that we can give oxybutylene also, but there is one specific word here mentioned, that is intractable nocturia. Okay, so there is this buzzword which will the answer is pointing towards the desmopressin, which is the first line drug if there is a history of nocturia. So in this case, desmopressin is the answer. Now there is a 55-year-old woman who is complaining of pain abdomen since 18 months, and cystoscopy done shows hemorrhagic spots and granulations. So what can be the diagnosis here? So cystoscopy, hemorrhagic spots and granulations are suggestive of the bladder pain syndrome, or we also called as the Hunter lesions, which we can see. Now, there is a 42-year-old woman who has complaints of leaking on cuff, that is stress urinary incontinence symptoms, and also increased frequency, urgency, and nocturia, that is urge incontinence symptoms. So, it's a case of both mixed incontinence. So, what is the initial step in the management of this patient? So, for initial step, okay, so we do bladder training because she has complaints of both. There is in her case, mixed case, where the cause is not clear, we do urodynamics also, but the first initial step they are asking, so first we do is the because she has symptoms of overactive bladder also, we do bladder training. So this is of the from the NICE guideline, where they say we do bladder training for at least 6 weeks as a first line treatment for women with urgency or mixed incontinence, as this patient has. And if it is not effective, then we do a combination of the medical management with bladder training. So now there is a 45-year-old woman who has been diagnosed with stress incontinence, and examination reveals cystocele. How would you manage the case now? So here she is a case of SUI, and which is again complicated by the cystocele, that is it's the anterior wall prolapse. So we know if it's a case of a anterior or apical prolapse complicating incontinence, then we need to do urodynamic study. So as we went through previous before, so this one of the indication is to do, and urodynamic study is incontinence with history of anterior wall prolapse. Now, during a burst colposuspension, which is commonly used for SUI, the surgeon notices torrential bleeding in the retropubic space. So, which of the blood vessel must have been injured? So, according to the anatomy, so bush colpo suspension, where we do place a hammock-like sutures between the vaginal wall muscles and the iliopectineal ligament. The closest artery there is the deep circumflex iliac artery, as you can see here. So that is the one. While placing the hammock-like sutures, that the artery is has increased risk of bleeding. Now there is a 45-year-old lady who is para 3 and is a gym instructor who presents with complaints of leakage of urine during exercise. So symptoms of SUI. Subsequent urodynamic study shows normal bladder capacity, free flow of 18 ml per second, and stable bladder. So what can be the most likely diagnosis? So bladder capacity is normal, urodynamic study is normal, because the flow rate we know it should be at least 15 ml per second. So it's 18 ml, which is normal. It's a case of a normal urodynamic study. So what can be the diagnosis? So she is a gym instructor. It's a risk factor. We know any condition which causes increase in abdominal pressure can increase the risk of SUI. So she has her occupational risk factor. So it's a case of urodynamic. It's a case of a stress incontinence. Okay, so answer here would be A, not D, because urodynamic study is normal. A 23-year-old lady who is para 2 presents with a 6-month history of stress incontinence. Her body mass index is 34 and she had a cesarean 11 months ago for breech presentation. What is the most appropriate management? So it's almost 11 months since her last cesarean, and she has complaints of SUI, and there is a risk factor, that is her BMI is 34. So what is the first line management? We know is the lifestyle measures. In this case, we will tell her to do the weight reduction. Okay, so the answer here is H, along with the pelvic floor muscle training. Now, there is a 46-year-old woman who had an abdominal hysterectomy 4 days ago and is now complaining of continuous leakage of urine per vaginum. A diet test confirms that she has developed a vesicovaginal fistula and is understandably very distraught. So it's a case of a VVF. What can be the management in this case? So It's almost 4 days ago. So the first line management that is done is to give the antibiotics and repair the fistula after 12 weeks, that is after 3 months. Now we will go to the SBS. So there is a 48-year-old woman who has complaints of incomplete emptying of bowel, requiring digital evacuation. She has no urinary symptoms. She has 6 kids, all delivered vaginally. The last kid was delivered by instrumental delivery. Her BMI is 37 and she suffers from COPD requiring treatment. Which of the following etiological factor has the greatest increased risk in developing pelvic organ prolapse out of all? Because she has many risk factors for developing prolapse, like her age, so her parity, 6 kids, and the history of instrumental delivery, and the BMI is high. Also, she has COPD, which can increase the risk. So, out of this, which is the most high carries the highest risk is the parity, that is having 6 kids, so there are, it has the greatest risk of developing pelvic organ prolapse. So any condition which can weaken the pelvic floor muscles, like increased parity, pregnancy, childbirth, aging, menopause, or histopelvic surgery, obesity, which can increase the pressure on the bladder and also increase the risk of stress incontinence, and other chronic conditions like diabetes or COPD can also increase the risk of prolapse, but parity has the increased risk. Now, there is a 54-year-old woman who has symptoms of urgency frequency of micturition. She was diagnosed with overactive bladder and has tried lifestyle measures, bladder training. So she has tried first line and she has tried the bladder training and also anticholinergic measures, which has failed to relieve her symptoms. Then she was started on Botox 800 units, but she is unable to perform clean intermittent catheterization. We know that to suggest them Botox, say they should know how to do clean self-intermittent catheterization. So, which invasive treatment for an overactive bladder is suitable for women who are unable to perform clean intermittent catheterization? So, the answer here is D, that is percutaneous sacral nerve stimulation. So, these are the third line measures, either Botox or percutaneous sacral nerve stimulation we can offer in those who cannot perform clean intermittent catheterization. And after that, if this fail, the other options are surgery, that is the augmentation, cystoplasty or urinary diversion. Okay. Now there is a 64-year-old woman who has complaints of incomplete emptying of urine. She suffers from chronic cough and also she is a known case of bronchial asthma and her BMI is 36. Her pelvic examination reveals anterior vaginal wall prolapse. In the POPQ's examination, what is the description of the point AA? So AA are the points on the anterior vaginal wall, and the APBP are the points we know are on the posterior vaginal wall while when we chart a POPQ grid. So AA is the point, the answer is D, where it is anterior vaginal wall 3 centimeters proximal to the hymen is that point. Okay, so the AA points AABA are on the anterior vaginal wall, APBP on posterior vaginal wall, and as you can see, if we take 3 centimeters above from the hymen is the point where we calculate as AA. And on the same side on the posterior wall is the BP point where it is 3 centimeters proximal on the posterior vaginal wall. Now, there is a 38-year-old woman who presents with chronic pelvic pain. Her pain decreases after emptying her bladder. She had her blood investigations done, which came to be normal. Her urine analysis is also normal, and a diagnosis of BPS is made. So, what is the most likely factor which can aggravate the pain in patients with bladder pain syndrome? So all these factors can be a risk factor for bladder pain syndrome, that is constrictive clothing, coffee, sexual intercourse, stress, spicy foods even. But of this, stress is the one which can has the highest impact on the symptoms of the bladder pain syndrome. Almost 61% pain had relation with pain. A 66-year-old woman has complaints of painless hematuria. Again, painless hematuria. So she had her blood investigations done, which is normal. Her urine investigations showed frank hematuria. She is again a chronic smoker, and there is suspicion of bladder cancer. When she is undergoing cystoscopy, she wants to know what is the most common problem for a woman following cystoscopy. So the most common problem. So most common if it is asked, so it can be mild burning or bleeding, which can happen during micturition after a cystoscopy. So it's the answer is B, that is mild burning or bleeding during micturition. So common risks and serious risks, rare risks. So common is there can be biopsy of abnormal areas or infection. Rare, but sometimes there can be serious risk like injury to the urethra or perforation, or there can be delayed deep bleeding. This can be rare complications can happen. A 55-year-old woman, sexually active woman, is diagnosed with wall prolapse. She had hysterectomy 10 years back for heavy menstrual bleeding. She is planned for abdominal sacrocolpopexy. What is the main drawback of abdominal sacrocolpopexy over SSF? So we know because she is sexually active, so for that probably she is undergoing sacrocolpopexy, because we know that is the preferred in them, because sacrospinous fixation can it decrease the vaginal length more, and especially those who have complaints of dyspareunia, so in them it may not be suitable. But what is the main drawback? Because so we know it is a major procedure, abdominal sacrocolpopexy, than the sacrospinous fixation. So overall the morbidity is more for sacrospinal abdominal sacrocolpopexy. That is the answer here is B, more overall mobility. But the most effective method, if you ask for the wall prolapse, is abdominal sacrocolpopexy, and also it is preferred in those who have complaints of dyspareunia or who have shorter vaginal length, but the mobility is more because it's an abdominal procedure. Whereas sacrospinous fixation, if the patient has history of major history of multiple abdominal surgeries, it is preferred in them, or those who are not sexually active, in them it is preferred. A 46 years old woman, he's undergoing sacrospinous fixation for wall prolapse and wants to know the risks associated with it. The nerve that is susceptible to entrapment injuries during SSF is which one? So it's the we know during the that the pudendal nerve, it is in passes in close relation with the with during the sacrospinous fixation, because it runs in the lateral third of the sacrospinous ligament, and at that time when it enters through the pelvic lesser sciatic foramen through the pudendal canal, it can be prone to a risk of injury. So there is a 45-year-old woman who attends the general gynae clinic with complaints of urgency frequency and urge incontinence. There is no past medical history and she is not taking any medications. Her blood and urine examination is normal, but she reports fecal incontinence. So how are we going to manage her? So here we see that she has symptoms of urge incontinence plus fecal incontinence, not only urge. So bladder training won't act, or desmopressin or oxytocin won't solve her fecal incontinence problems. So here the answer is referral to a specialist service. So if there is a complicated case of incontinence, if there is history of associated fecal incontinence or neurological problem, or if there is associated pelvic mass, or if there is previous surgery of incontinence, in that case we refer to specialist service. A patient presents with symptoms of a prolapse. She has complaints of increased frequency and incomplete emptying, voiding of urine. On examination of POPQ system, the score you can see. So we know on POPQ system, the higher the higher the minus is the score, means that there is less risk of prolapse. As it approaches the hymen, the score becomes 0, and when there is a greater degree of prolapse, if it is given numbers as plus. So here we can see the anterior wall, the AABA, as I said, are the anterior wall points, APBP are on the posterior wall, and C is cervix, and D is the posterior fornix. TVL is the total vaginal length, and GH is the genital hiatus, and PB is the perineal body. So all other points look normal, or how they should be, but the AA and BA are 0, that is, they are at the level of hymen. So what can be the diagnosis? There is anterior vaginal wall prolapse. There is no posterior vaginal wall prolapse. It is well supported, and there is the D point is there, means that the patient had not had hysterectomy before. So here the diagnosis is the correct answer is B, that is stage 2 cystocele and anterior repair, because there is anterior vaginal wall prolapse. Now the patient has complaints of constipation and incomplete emptying of bowel. So now you can see the anterior wall is well supported, but the points AP and BP are at the zero level, that is at the level of hymen. So there is enterocele, you can see, and the other points are in the normal plane. So here the diagnosis is stage, the D point is there, means there is no post hysterectomy status. So answer here is stage 2 rectocele and posterior repair. Answer is C. Now a 28-year-old woman presents 10 days after an anterior colporrhaphy for cystocele, and she has complaints of constantly, okay, there is constant damp vaginally, and is wearing having to wear pads continuously. So we know after surgery if there is continuous leakage of probably it is a urine, so it's a case of a vesico-vaginal fistula. Now, there is a 59-year-old para 6 woman presenting with urinary incontinence and a mass in her vagina. She has tried pelvic floor exercise, but they have not helped her symptoms. So, para 6 is an increased risk factor with urinary incontinence and plus mass in the vagina. So, what can be the further management is in this case is the urodynamics, because it is incontinence with associated urinary symptoms. Most likely she has anterior wall prolapse, which requires a urodynamic diagnosis. Now there is a 46-year-old woman who has had 3 previous vaginal deliveries and presents with 2-year deteriorating history of leakage of urine, and it is SUI, symptoms of SUI. On examination, there is moderate cystocele and rectocele also is observed in this case. So it's a case, there is symptoms of SUI. So what can be the diagnosis here? It's C, that is urinary stress incontinence. Now, there is a 40-year-old multiparous woman who was referred by her GP due to prolapse and mixed urinary incontinence. She has grade 1 cystocele, rectocele. There is no stress incontinence demonstrable, but there is features suggestive of prolapse and mixed urinary incontinence. Her bladder diary is suggestive of frequency and urgency. So, what is the most initial management option? Okay, so most initial, so first line management we give is the physiotherapy and bladder training. So it's a case of most incontinence predominant. So here the main first line management is physiotherapy and bladder training. So if a patient is undergoing cystoscopy, so what is the true contraindication, that is absolute contraindication to do a cystoscopy? So all others are contraindications, but relative. But if there is history of untreated UTI, so that can flare up the infection. So that is a true contraindication or an absolute contraindication to do a cystoscopy. So, of the following, which antimuscarinic drug is used in the management of overactive bladder, which should be avoided in frail older women? So, most common drugs used are the oxybutynin. The maximum age to use is it shouldn't be used above 65 years because of the side effects. And in the preferred ones in the old woman are the darifenacin. So here the answer is oxybutynin. So it is avoided in frail older women, and because of the side effects. So proper history and examination should be taken in these patients to rule out any contraindications, the age. Okay. So that was all, guys, for the urogynecology module. I hope this will help in your exam preparation. Thank you so much.